We are live, please.
Um, Good evening, everyone. Should we start?
Yes, doctor, we are live.
Yeah. Good evening, everyone. And I'm excited to be back here again for today's webinar on must know practical pearls of refraction by Dr. Krishna Prasad. Sir, as we all know, is the gold standard when it comes to teaching refraction. And more precious, and he's a recipient of at least 9 gold medals during his academic years. And more precious than that, I should say, is his passion to teach refraction and share knowledge with everybody. His zeal for creative teaching and innovation, we are all aware. Uh, just as a brief introduction, he's the director and head of pediatric ophthalmology and glaucoma at Joshi Eye Hospital, Hooghly. He's also the director of PG teaching and fellowship. I would also like to introduce the chairperson of today, Dr. Mahesh Babu. He is the professor and head of Department of Ophthalmology, Subaya Institute of Medical Sciences, Shimoga. He is also the member of the scientific committee AIOS, managing committee member of Karnataka Ophthalmic Society, and also the member secretary of ethics committee in his institution. So with this, I would ask Dr. Krishna Prasad to take over.
Thank you, Dr. Sheetal. Is my slides visible?
Yes, sir, it's visible.
Okay. So welcome back. So this is the third episode in the 4 webinar series on refraction, as requested by our dynamic chairman scientific committee, Dr. Namrata Sharma. And it has been a very useful thought by her that refraction, which can be useful both for postgraduates and practitioners alike. And we are trying to crystallize all the useful information, very applied refraction in the form of 4 webinar series. So this is the third one in the process. And I'll be very happy to share some of the very practical pearls which are must know. I think this is a very desirable to know these for our routine refraction. So it's about the vortex distance. This is what is it? It is basically the distance from the eye to the spectacle glass in the frame. So when we wear a spectacle, how far is that spectacle frame from the eye is literally called as the vortex distance. But theoretically speaking, it is actually the from the nodal point of the eye, so to the correcting glasses. So this will actually decide the effective power of the prescription. You may give any number, you may give -2, you may give +1, but it is basically you are trying to denote that wherever you have put the trial lens in the trial frame, when you are actually doing the subjective correction, that distance, this patient is going to accept -2. So just like we give a prescription, we also have to specify the vertex distance ideally in a prescription. Because if your trial lenses are 12 millimeters from the eye and you say it is -2, and if the patient makes a spectacle in which the glasses are sitting at 15 millimeters from the eye, then that power will not be -2 anymore. So this is important. So the effective power of the prescription, even though that means even if the patient, let us say, has a particular refraction of -2, let us say, if you put the trial frame very close to his eye, or you keep it in the end of his nose, then also you may actually do a refraction and get the power. And when the person wears a normally situated spectacle, so it can be an abnormal spectacle or it can be an abnormal trial frame situation. So you should make sure that the trial frame where it sits, the spectacle should sit. Because we are never there when the patient selects the frame. He goes to the optical shop and he can fancy any kind of frame, and his noses are different, patient's facial features are different, the present day style and the fashion is different. So it all actually amounts to, especially if the refractive error is on the higher side. For a patient who has probably -1 or minus zero .5, slight variation of 1 or 2 millimeters of vertex distance may not really matter. But let us say a patient is wearing -5 or -6, then this change in the vertex distance will really play the spoil sport, and this can be a source of error or a source of discomfort or even dissatisfaction of the patient. One very useful tip is it is easy to know that whenever the convex lenses become stronger when they move away from the eye. So this is important. That means if the patient that has a convex power of, let's say, +6, it is sitting at 12 millimeters. If you shift it to 15 millimeters, then it will not be +6 anymore. It will be more than +6. You get the point. So when the patient slides the spectacle down the nose, then he's actually adding plus power to it. This is a very commonly observed fact. We are from the ICC era where we used to do in the past, 30, 40 years ago, we used to do ICC in the camps and prescribe aphakic glasses. We were not giving them bifocals. It was very difficult at the community level to give bifocals. We would give +10 for everyone. But the patients are pretty happy because +10, they are very happy for distance because there's also a magnification factor. The distance would always be 6, 6. And if they want to read something, they would just slide the spectacle down their nose. A +10, if you slide it down the nose, it will become +12 or +13, and that would be an instantaneous near addition for the patient. So with a monofocal lens, the patient was enjoying the benefits of a bifocal lens just by moving it down the nose. So at the same time, a negative lens, a minus lens, it becomes weaker when it moves away from the eye. That means a -6 spectacle sitting at, let's say, 12 millimeters. If you move it to 16 millimeters, it will not be -6, it will be less than -6. This actually also works good for the near correction. For example, let us say there is a patient in the pre-presbyopic age group or around the presbyopia age group. Let us say there's a patient who's wearing -5 for distance at around 38, 39, 40 years and not ready to wear a bifocal. What you can ask him to do is you just has to move the spectacle slightly down the nose, keep it little away from the eye. A -6 power would become a -5.5 or a -5, which is essentially an addition of a +1 for his near activities. So a myope would, if you slides it down, he will see near better, and a plus power, a hyperope, if he moves it down, he will see it better. So basically moving the spectacle away from the eye will help like a positive or a convex lens addition. So this has been seen and has been a practical experience of a lot of patients like this. So this is something that you should know. But if this is not the situation, making a spectacle which is sitting away from the eye or very close to the eye can be a problem for the patient's subjective experience. And the same thing is also applied in contact lens prescription. You should know that a aphakic glasses, which is traditionally +10 as a spectacle, if you want to give an aphakic contact lenses, it will be around +13 or +14 rather than +10. That means when it moves towards the eye, you need a higher power. Okay, you need a higher power. As contrast, if it moves away from the eye, it becomes more powerful. So at the same time, the same correction, if you want to give it in terms of an intraocular lens, it will be maybe +20 or +22. So a +20 lens in the bag would be around +18 or +19 in the sulcus. It will be a +13 or a 14 on a contact lens. It will be a +10 at the prescription, at the spectacle level. So this is important that there is a change in the power that we prescribe as the location of the correcting lens changes. So similarly, if you are giving a contact lens for a myope, for up to 5 diopters, usually the change is very small. but because you don't get a contact lens of very small denominations. But once after 5, normally this change becomes significant. For example, if the patient has -6 spectacles, his contact power will be lesser, unlike a plus lens. So it may be around 5.75 or 5.5. And it comes to, let's say, -10 spectacle would be requiring a -9 contact lens. So this is important. So it's very important to know that. So obviously, you need to put the contact lens based on the spectacle power, but you have to do an over refraction because the effective refraction will change when you make a spectacle into a contact lens, which is basically because of a vertex distance effect. So the refractive errors and the ocular balance. This is something which cannot be overemphasized. Whenever you are giving a glasses or a refractive correction, please do a cover test. The patient may have a phoria, an exophoria, or a esophoria. So it is mandatory. The gospel truth is in all exodeviations, be it a constant exotropia, an intermittent exotropia, exophoria, fully correct myopia and slightly undercorrect hyperopia. This is the dictum that everyone has to follow. Okay. At the same time, in contrast to that, in all ESO deviations, be it esophoria or intermittent esotropia or a ESO deviation, fully correct hyperopia and undercorrect myopia. Let me give a practical situation. Let us say a patient is wearing, let us say, plus 5 hyperopia correction. If he's probably using plus hyperopic correction, the patient is having straight eyes, he has no complaints of squint, and you do a refraction, you do a cycloplegic refraction, and the patient accepts +7. So you do a fogging and give the patient +7. When you give a +7, which you want to achieve 6.6, then what happens? The patient may wear +7, but soon will come back with a complaint that the eyes are deviating out. There is an intermittent exotropia, which is cosmetic blemish for the patient, and they will complain after wearing this new spectacle, my eyes are squinting. So, how did this happen? The patient was an undercorrected hyperop. In order to correct the two diopters of hyperopia, which was not corrected, the patient was using the accommodative convergence. When the accommodative convergence, when he was using his accommodation, basically, when the two diopters of accommodation happens, the accommodative convergence also kicks in, which was used to basically neutralize the exodeviation. The patient's convergence was stronger because there's an additional accommodative convergence because patient was actually using accommodation to clear his distant vision. Now that you have corrected all the +7, the patient need not accommodate for distance. So there is no accommodative convergence that is coming in. So his exodeviation, which was hitherto well corrected, now became now manifest, or it started becoming an intermittent exotropia. So similarly in ESO deviation, you have to, like you know that in children, especially ESO deviations in childhood, it can destroy the binocular vision. So it's very important. A child has an accommodative esotropia, and if you probably don't correct the hyperopia fully, the patient can squint, and patient can the binocular single vision can be it can be detrimental to that. So it is very important that the very formative years, in the age of plasticity, you need to align the eyes at any cost, which means fully correct hypermetropia. At the same time, if the patient is a myope, slightly undercorrect myopia in order to maintain straight eyes. So, cover test has to be done for near and distance when you are in doubt. And any patient having an exodeviation, don't compromise in giving full correction. There are cases where we actually slightly overcorrect myopia. Let us say there's a patient of intermittent exotropia. The patient is rating actually -2.5. He needs a 2.5 for 6.6. I will not hesitate to give -3, a zero point 0.5 overcorrection, because that overcorrection will actually stimulate, okay, his accommodation, will accommodation convergence kicks in and he will be able to straighten the eyes. So fully correct or slightly overcorrect myopia can be another statement. And the holy grail of refraction, we told last time that the lowest myopic correction and the highest hyperopic correction compatible with BCVA. So why this statement? Why should we give a lowest myopic correction? See, it happens that let's say a patient is -2 and you give -2, patient is 6.6, and you go one step ahead, you give -2.25, patient still reads 6.6 and the words become very clear, small and crisp. Patient thinks it is better. He wears -2.5. He's still seeing 6.6. So it is very difficult for the patient to understand where to stop in myopia. So the BCVA has already been achieved at -2, but the same BCVA is also at -2.5. So you should give a lower correction or the lowest correction, that is -2. Anything less than -2, he may not read 6.6. So at the same time, hyperopic correction. Let us say a patient reads 6.6 with +2. A patient with all fogging and all our efforts, patient also reads 6.6 with +3. Then you should be giving a +3, not +2. What is the whole logic of this statement? If you give a, if you use the lowest myopic correction or the highest hyperopic correction, what you are going to do is basically relax the accommodation for distant use. You are discouraging the patient from using accommodation for far distance. Imagine if you don't give full hyperopic correction. Let us say instead of +3, you are giving +2. The patient has to make good for the remaining one diopter by accommodation. For distance, accommodation is meant to be used for near. It is not for distance. It is a misuse, it's an abuse. So if the patient uses accommodation for distance, it is an abnormal situation. So habitually some patients use that. So that means one diopter is used up or misused for distance if you do not give highest hyperopic correction. Similar thing happens for myopic also. If you undercorrect myopia, there is sometimes in some of the people think that the myopia should be undercorrected, which is absolutely wrong. Myopia should not be undercorrected. Maybe this idea came because there is a possibility of overcorrecting myopia. That's why you should do subjective corrections, which was told in the last webinar. We have so many subjective methods by which we can refine the sphere of the spectacle correction, but you should never intentionally undercorrect myopia. That's because if you undercorrect myopia, patient has to use accommodation again. That is a misuse of accommodation. So this should be very well understood, and this is the final dictum that we all follow. And the most important aspect, presbyopia. Presbyopia is a huge challenge to humanity. Presbyopia is an age-related decline in the amplitude of accommodation, and we actually, all of us suffer from it at some point of time. And now, presbyopia is very, very important. It was important at any point of time, but the present times have seen a new dimension in the problems faced by presbyopia. Earlier, illiterates and the rural folk who are not into reading, who are not very much affected by presbyopia. Okay, they would read only once in a while to thread a needle or something like that, so for some handicraft. But now the cell phone use has made everyone dependent on near glasses. Once you age cross, let's say for 35 or 40, then you will not be able to see the small print. You will not be able to see the things on the mobile screen. Then everyone needs a presbyopic correction. And more so now, a lot of things, our day-to-day activities are linked to our mobile use. For example, it may be a boarding pass, it may be an OTP, it may be an important photograph, it may be some information that is coming on the screen. And if you can't, you are not able to see that, you may have a lot of problems with your quality of life. So presbyopia has been the major bugbear for most people. And presently, the patients are very intolerant to presbyopia. This is very important. Now, some of them are so much worried about it, their dependence on glasses. It can affect their quality of life. And sometimes that usage, it can trigger migraines. It can create so many problems. So presbyopia is now extremely important. So to understand that this presbyopia can present in multiple varied presentations. See, presbyopia is not something to do with age only. It is not a numerical number game. Like people say, at 40 you get presbyopia. I think why do you get presbyopia at 40? Okay, I would rather jokingly say you would not get presbyopia at 40 if you did not have an elbow joint. Meaning to say that we have a humerus and ulna. Let us say if that were to be one single bone. If you are not flexing your arm at the elbow, you would be keeping things at a very far like this. You will be keeping everything at a greater distance from your eye that probably presbyopia would have come at 50 or 55. And if you were to have short arms, upper limbs, if your elbow, if your humerus were to be very short, ulna were to be very short, we have a very short upper limb, then you would have held everything, the things very close to your face, and you would have had presbyopia at 30. Basically, what I'm trying to say is it is the routine, traditional, conventional usage of your working distance. Most people use, conventionally things at around 35, 40 centimeters because of our force of habit of keeping things and doing things. We get presbyopia around 40 years. If you have a habit of keeping things very close to your face, you will get presbyopia at 30 also. And if you're traditionally, conventionally using it a very far off from the eye, you will have presbyopia at 50. So it is depending upon the working distance and the convention that we use. So, but most people, so you don't be surprised somebody complains of presbyopia at 35. Okay, he may be a hyperope too, but they can have an actual presbyopia being a metrope at 35 or 45 or 50, depending upon their physiology. At the same time, before what normally presbyopia is, you can't see the near objects. Patient will have a blurring for near object, but that doesn't happen in one day. Before that, there is another phenomenon. Patients usually complain at 35, 40, especially they are into screen. They say, I'm looking at my computer screen and I look away for something and I'm not able to see for a while. For some time, my vision is blurred. What is happening? The slow relaxation of accommodation is also the earliest sign of presbyopia. A lens which is molding very easily, okay, like an young person's lens, it molds very quickly. Within 0.3 seconds, they say that it changes the shape from distance to near. If somebody, if a child is looking near and looks away, very quickly the lens changes the shape. Whereas as the lens become aged, the contents change, the capsule, the capsule elasticity changes, then it takes a while to change the shape. So you're looking at screen in the presbyopic age group and suddenly look far, the lens is still in the accommodated state, and when you look away, it is still blurred. Slowly it will recoil, it will change the shape and things get clear. So this slow, accommodation or the process of changing the lens shape can also be an earliest sign of presbyopia. And presbyopia is not to do with the contents of the lens. Presbyopia is to do with the capsule changes. Our lens capsule changes drastically, its elasticity changes. That is the reason why the lens it varies. So the presbyopia has, but once really the lens cannot mold properly maximally, then you will have a problem. So it is related to the working distance, not by age. So how do you correct presbyopia? Optical. We're talking about spectacles. We're having even contact lenses now. People who do not want to wear spectacles can wear presbyopic contact lenses, which come in multiple modules. Now we also have some cornea-based procedures. There was a conductive keratoplasty. There was some lens corneal implants like Cambra implant, which most of them are temporary. They do not offer a lifelong solutions, and they can also be invasive. Pharmacological agents, there is a new interest. Like you can put things like pilocarpine to constrict the pupil, and also to stimulate the ciliary muscle. So this can work like a short-term thing, like you will use it for some time, you use and for few hours, your accommodation system is more robust. Again, in the early presbyopes, it works better with all its side effects. But at the same time, there is a very specific role for pharmacological agents in a very specific patient for a specific indication. Lens-based procedure, of course, this is a new indication for us for cataract surgery. Patient does not have a so-called a cataract as in a lens opacity, because the definition of cataract is a lens opacity. This patient has so-called a clear lens, but the lens is dysfunctional. As you age 40, 50, 60, the lens looks clear. Even distant direct ophthalmoscopy show the real very red glow. So clinically or by definition, there is no cataract. But look at this lens. This lens, the capsule has become inelastic. The lens contents have changed. The nucleus become harder. There is a chromophore and new coloring material that has come in. The lens color has changed. It has changed the color discrimination pattern. There are changes in the color discrimination. At the same time, this lens is now showing presbyopia. It can't mold anymore. It can't focus for near and distance instantaneously. So this lens is now aged. It can't mold, the contents have changed, the color has changed, so its contrast sensitivity is changed, there's a glare disability. So many things, the photic phenomena, so the quality of vision has come down. Patient may read 6/6, but on a Pelli-Robson chart or a contrast chart or some specific task like a glare disability, patient will underperform. So this is pushing the narrative to plan for an earlier lens-based surgeries. Now that we have a basket full of trifocal lenses, toric components, where you can correct this presbyopia and even the corneal astigmatism in a very effective way, in a very safe way. Also, that there is a argument that this lens surgery has to happen in later on when the eye actually gets a cataract. So we are just preponing the inevitable surgery now for the perfect solution for presbyopia. So the days are not very far that we may be preaching a lens-based surgery for presbyopia, but till then we need to understand how to prescribe in presbyopia, right? So the patient comes with a presbyopic symptoms, how to decide the class. It is not by age. It is not that at 40 you give +1, at 45 you give +1.5. Never it is done like that, because I told you everybody's physiology, everybody's amplitude of accommodation is different. So basically there are two methods. One is a very theoretical method, that is measuring the near point of accommodation and then calculating the amplitude of accommodation and then planning or getting an idea what should be the correction. This is more theoretical. It has to be subjectively tested. You cannot just measure NPA and amplitude and give the glasses. It has to be subjectively tested. Okay. The next is a subjective fine tuning, which I'll come to that. So for postgraduate, it may be very interesting to know what is NPA. The near point of accommodation is the point closest to the eye that can be seen clearly with maximum accommodation. So you bring an object, get it closer to the eye. At certain distance from the eye, it becomes blurred. That only means that the patient has used maximum accommodation to see it clearly. That means, let's say he sees it at 25 centimeters. So it is 25, 100 by 25, that is 4 diopters of amplitude of accommodation. So this is how we check. So the whole logic of understanding the amplitude of accommodation, what is the maximum accommodation left in the patient? And it is very important to know that you cannot make a patient use 100% of their accommodation all the time. Some amplitude of accommodation has to be left unused for routine work. In the sense, let us say if the patient has 4 diopters, this is 25 centimeters NPA, and 4 diopters is his amplitude of accommodation, You can't put that 4 diopters into use all the 24 hours. Maybe you can use 3 diopters, and one more diopter has to be kept in reserve so that the patient is comfortable and can use it intermittently. I normally give the example of a weightlifter. If a weightlifter can, let us say, 150 kgs in a sporting game, and he probably becomes a champion, so that means he has lifted 150 kgs of weight, okay, to win the gold medal. Do you think that he will be or she will be able to lift 150 kgs throughout the day? No, but probably they can lift 100 kgs for most hours of the day. So that is what it is. What is the maximum potential or the ability has to be used sparingly for comfort. So let us say, I will give an example how to give a presbyopic correction. Imagine there's a patient who comes with he's 6'6" for distance and let's say N10 or whatever, needs a presbyopic correction. You basically first check his NPA. His NPA is, let us say, uh, 33 centimeters. At 33 centimeters becomes blurred. So 100 by 33, he has 3 diopters of accommodation with him. Normally, 1/4 of the accommodation is always kept in reserve. So 1/4 of 3 diopters is 0.75 diopters. So when you ask him to read the near chart, see, consider this. Imagine the situation. He comes to your OPD, you give him a near chart, ask him to read the last line or whatever. Now he is trying to read it, putting all his accommodation. That is what it is. He will not underuse it. Now he's trying to use like the 150 kg lifting. No, he's trying to use all his accommodation to read it. So don't consider that as a normal situation. Just because he has read it once, the whole day he cannot read that N6. So that is what happens. Many a times when pre-presbyopic patients come, we give them the near chart, they read N5. So we think that they are fine, they are okay. But I told you they have used their full accommodation to read N5, and throughout the day they can't read N5. They will have asthenopia if they are trying to do that. So they may actually need a small correction so that we can relax a bit of accommodation so that they can have a better comfort throughout the day. So similarly here, this patient, 3 diopters are in his kitty, 0.75 is something should be left unused. So the least correction with which the patient is N6, let us say he's 45, you give him +1 and he reads N6 or N5. This is the least correction. So what you do is you add that extra 0.75 diopters to this correction and give him 1.75. So 1 diopter is his correction and 0.75 is the additional correction to relax 1/4 of his amplitude of accommodation. So this is a very theoretical method. We don't normally use it in clinical practice, but in practice, we use what is called a subjective fine tuning. So I will tell you how it happens. A patient comes, we give him a near chart. He reads, let's say N10. You give him, let's say, +1.5. He reads N6. So should we prescribe 1.5? See, the problem is 1.5. There's a small risk of it may be a overcorrected thing or it may be undercorrected thing. So you need to guard this prescription against overcorrection and undercorrection. How do you know that you're not overcorrected with 1.5 or undercorrected? So let us say at his working distance of 40 centimeters, he's reading N6 with 1.5. You bring it closer by 3 inches. Once you bring it closer by 3 inches, the patient says, I can't see. That means you have undercorrected him. He is using all his accommodation and anything closer he can't see because he has no accommodation left in his reserve. So here basically undercorrect. 1.5 will be lesser for him. You need to increase it. Number two, how do you see that he is not overcorrected? At 40 centimeters, you take it little backwards by 3 inches. If you take it back, if you have overcorrected him, he has to relax his accommodation to see it clearly, which cannot happen. So it will become blurred. So the things at the working distance, If it becomes blurred when you bring it closer, you have undercorrected him. If they become blurred when you take it away, you have overcorrected him. So by doing this, so that means you have to see in a range in front and behind the working distance. There has to be a range of clear vision so that the patient, this is a more practical way of giving glasses. Otherwise, if you just check one distance and give it, you may end up with a overcorrection or undercorrection. Patient may not be happy over a distance. He has to bring everything to that distance, which is not practically possible. So this is how it is. So NP, I told you, you can use RAF ruler or a Prince ruler. You can even just do it approximately without this also, and convert that into amplitude of accommodation by 100 divided by LPA in centimeters. Okay, and keep 1/4 of 1/3 as a reserve for the minimum correction, so that this is one method. And of course, you have bifocals, which can be cryptok, D-type, or executive, progressive addition lenses. So there is a lot of myth about PALs or progressive addition lenses. A lot of times people think that people do not get adjusted to progressive addition lenses. There are a lot of patients who are dissatisfied about progressive addition lenses. They're very cost intensive, so better not give costly glasses, which patient may not sometimes get used to. I think that era is over. The present day progressive addition lenses are extremely good because the corridor or the area in which the distortion free vision is there has increased. And what are the things that really go? What makes a PAL very attractive, versatile is there is a range of clear vision. Okay. It is designed as such as the eye moves. Like for distance, we keep the eye straight. For intermediate, we keep it in the midway. For very up close, we have to bring the eye really down so that the distances required for the correction for the distances are adjusted accordingly. It progressively increases. Let us say if you are given a plano and plus 2.5 as a progressive, the 2.5 is not in the middle. 2.5 is in the extreme end. It is starting from 0, 0.25, 0.5, like that. It keeps on increasing. And 2.5 is in the lowest portion of the spectacle. That means you can't read very close, small print from the middle of the glass. So if the lenses are decentered, then PAL really falls flat. This is very important. So making the spectacle as per your face, fitting the choosing the proper frame, fitting the glasses as per your interpupillary distance and your eye position, the pantoscopic tilt, all this is very important for a very satisfactory PAL fitting. Because the patient can see a range of distance, they are very comfortable. They don't have to move their neck. They don't have to strain their neck to really reach out with by bending downwards or going backwards. And they don't have to crane their neck to really see things. So PALs is the way to go. Only thing is there's an initial adjustment period with most of them. And please understand that somebody who has used a cryptok lenses may find a PAL habituation difficult. So your best shot is the first time user. If the patient is a first time presbyopia correct, user, then hitch him on to progressive lenses. So they will get used to progressive in the beginning itself, and that will be a great service to the patient. If you put them on cryptok with all the disadvantages of cryptok, so they may not get used to progressive later. And there's a small segment in which the patients can use a monofocal for near also. Patient, all of them are not interested in and bifocals. They have only a limited, for example, patients who have find it difficult to really see through the near segment, patients who read a lot, okay, and sometimes who do not have number for distance, only for near, you can give them only correction for near. You can even add the distant correction also into it. So you can give a full frame. The entire spectacle will have a near correction. Of course, they can't see far with that. They have to only use it. So use the correction properly. And some of the patients, especially some of the Old people, patients are very happy with the monofocal for near. That is something that you can always give. And post-operatively also, a lot of bilateral pseudophakics are very happy to see their near print, like especially the cell phones, with a monofocal for near rather than a bifocal, because they have problems navigating with that. And patients who have macular issues, ARMDs and macular issues, then you can probably even step up the cover like a low vision aid situation. So monofocal for near, giving the only near correction as an entire spectacle can be an excellent tool in some patients. Can you delay presbyopia correction? So patient is complaining, what can you do it? There are ways by which you can probably delay giving the glasses. The presbyopia correction, presbyopia is linked to working distance, not the age. Okay. So you can find out habitually what the patient is doing. Patient is complaining that he can't see, but where is he keeping his reading material? If you tell him that if you probably keep it 2 or 3 inches away, you may probably delay it by a 6 months or 1 year. He may actually just that good at the correction. He wants to see at the distance that I've been seeing for the last 40 years. But if you say that instead of wearing glasses, you change the working distance, it can actually help a lot. It can even prevent asthenopia, and it can be like a trick. Most patients would have discovered it by themselves. They will figure it out by themselves, but they need some kind of a justification from you that it can be done. It can be done. Like a lot of myopes, low myopes, they take off their glasses and they can read, but they're worried. Can I do this? So doctor has given a presbyopic correction or a bifocals, but without glass also I can see for near. But they say it should not be done. Somebody will say, no, don't do it. So they need some justification or some kind of an approval from you sometimes. Okay, so you can say, keep it away. You can delay the presbyopic correction. Number two, patients who are myopes, moderate myopes, they develop presbyopia, small decrease in the distant correction. For example, somebody using -6, okay, and maybe reducing it by 5.5 in the next classes, both eyes, may not really make a big difference to the distance, but it can actually help the near. So you can tweak the distant correction in select cases to delay the presbyopia correction. And pharmacologically now there are agents. I told you there are a lot of drugs available as topical medication, and they can use it as per an occasion to basically, if they have a situation to read for near. At the same time, a bright light on their face, a brightly lit room, a brightly lit situation will constrict the pupil, increase the depth of focus, and they can actually see better. And of course, change the fonts and brightness and contrast, they can do well. So some useful tips in pseudophakics is, see, pseudophakics, let's say the emmetrope at a monofocal lens, we must be thinking that they can't see anything for near. We have knocked out the lens. There is no accommodation left, and there's a monofocal lens, and they are emmetrope. That means they have no myopia. So they should be reading really very less for near. It may not be so. Lot of patients, bilateral pseudophakics, monofocals, they do read quite a bit without any correction. We call that as pseudo accommodation. So how does that happen? Because most of the old people will have senile meiosis. Meiotic pupils help increase the depth of focus. Number two, some of them may have a very small myopic cylinder, but still they are 6'6". That small uncorrected myopic cylinder may not distort the distant vision, but can help for near. And the third thing is the spherical aberration. We always say spherical aberration is an enemy. Not really so. Some uncorrected spherical aberration. See, any spherical aberration works like a myopia. That's why dilated patients will complain of blur because of the spherical aberration which is uncovered. We also call it as night myopia, where patients, when they go in dark, they see far less because of the spherical aberration which is acting like a myopic glasses. Okay, there are some drivers, night drivers. They are okay in the morning, but evening they say they can't see the far off things well. You just give them 0.5 myopic correction. They will be able to see immediately clearly for distance. That is a typical example of a night myopia because of spherical aberration. The same spherical aberration helps pseudophakic patients to see for near. So don't assume that the patient always needs a plus 2.75 or plus 3 to see near just because they are bilateral pseudophakics. Contact lens users. See, when you are using a myopic contact lens, your presbyopia comes early. Let's say somebody is using -5 contact lens for a long time as an adolescent. When they are reaching 35, 40, they get their presbyopia earlier than if they were to be using spectacles. Okay, this should be kept in mind. And hyperopes above 30. For example, a lot of hyperopes, I told you, hyperopia can be corrected by exercising accommodation for distance. So many hyperopes in Engage are very comfortable because they are misusing their accommodation. They are able to see far, and the remaining accommodation they use it for near. But once they reach around 30 plus, then this division of accommodation between distance and near becomes a problem, this partition. So since they're misusing the accommodation for distance, they fall short for near. So you may have a patient coming with presbyopic symptoms early, like at 30, 31, 32, they say that I can't see small print. That only means that please rule out a hyperopia which has not been corrected. So you get a situation, tricky situation sometimes. The patient will not accept a +1 or +2 for distance because they have been using their accommodation habitually. It's very difficult for them to relax, even with fogging. But they may just need an additional +1 for near work as and when required. So usually the ideal thing would be to correct their hypermetropia so that they don't need a near correction. The accommodation which is released can be used for near. And myopes with bifocals, I told you, if you are having a patient who does not want to use a bifocal, slightly you can reduce the distant correction, not to disturb their distant vision. They can still be very happy. And at the same time, most people think that if one eye requires plus 1.5, other eye also requires 1.5. They don't check in both eyes. They put glasses in both eyes equally and see. Don't do that mistake. Even though the patient is of the same age, like for example, patient is 45, for the right eye also he is 45, for the left eye also he is 45. So you may think that his presbyopic correction will be same. No, there are many individual factors in the eye which can decide the amplitude of accommodation. Let us say patient has a blunt injury in one eye. He had some kind of a ciliary muscle damage or a fibrosis or some kind of a muscle injury during that blunt trauma, or there may be some kind of a uh, you know uh, tear in the ciliary body or some damage. So his contraction of ciliary muscle can be less. So he may actually have a poorer accommodation in that. He may require a higher add to see N6 from the other eye. That's a unilateral uveitis. A uveitis, healed uveitis, can actually reduce the accommodative amplitude in a patient. So glaucoma, unilateral glaucoma. So there are such diseases which affect one eye or an asymmetrical involvement. They may actually require an unequal add for near, not that it is always equal in both eyes. So presbyopia, please check the range of clear near vision before prescribing, as I told you, to avoid under correction and over correction. And this is very important. And it's why I think this is just a trivia. Like normally when we use retinoscopy, we said 2/3 meter. Never do retinoscopy very close to the patient. This can be if you are doing a retinoscopy, okay, if you do too close, then the correction factors becomes too difficult for you to manage. So slightly go away. Normally 2/3 meter is a right balance between this correcting mechanism as well as your potential to, I mean, change the glasses. Okay. And also when you do a retinoscopy, just because there's a neutralization, don't stop there. Go forward till the reversal happens. So many a times we can miss the point. So only the reverse will say that we have reached the neutralization point. This is just a trivia. Another trivia is if you don't have an occluder in the trial set, what will you do? Normally, we can use a Maddox rod if you don't have an occluder. Okay. So next is see, over refraction. This is a very important trivia that you should know. What is over refraction? Like if you do retinoscopy over the glasses which are worn or contact lenses. For example, your patient comes, you want to know whether his refraction, his present refraction and the glasses that he is using are matching or not. So the easiest thing is you put a plus 1.5 on the spectacle and do a retinoscopy. It should actually neutralize at 2/3 meter. So, wearing a spectacle, the patient should behave like an emmetrope on retinoscopy. That means there's a neutralization with 1.5 2/3 meter. So, this over refraction will immediately tell you that the glasses are correct. Okay, and there's no need to change the glasses. And also in contact lens trial, for example, I want to give a trial of contact. Patient is having -3 myopia. I have, let us say, -3 contact lens. I put the contact lens, show them everything, and over that, I do a retinoscopy or do a AR. Normally, whatever the refraction that you get has to be added to the contact lens. For example, if I do put a -3 and do a over refraction, he patient may be, let's say, 0.5 hyperope. Then I need to actually give him a 2.5 diopter contact lens, not 3 diopters. So you have to basically fine tune the power of contact lens by refracting over the contact lens. All the spectacle power, when it is transported to as a contact lens power, over refraction is extremely important. And the last one, which is very important, is the centering of spectacle. See, this is very important. Like we give the correction, some complex refraction, and patient goes somewhere else and buys the spectacle, and the patient can't see well. Patient is very uncomfortable with the new glass, and the optical shop person says, please go back to your doctor. We have done as per the prescription. And the lensometer says the cover power of the glasses are correct as per the prescription. So where is the source of error? The source of error is the optical center of any spectacle has to be exactly coinciding with the patient's visual axis. This is very important. Patient visual axis has to coincide with the optical center. Because optical center is that center in the spectacle, the line passing through it will go unrefracted. Anything the line or light going on either side will have a prismatic effect. If the optical center is decentered, okay, and the eye is here, the center is somewhere else, the eye is looking at by the side of the optical center, so it giving a prismatic effect which can cause discomfort to the patient. So this is very important, how to find the optical center of a spectacle. Okay, and higher powers create a lot of problem with decentration because the prismatic effect will be much more. And this is a very common problem because nowadays there is no much of a problem in spectacle making. They make any complex refraction corrections very easily. It is all done by automated machines. But the problem is the centering. Because normally what they do is they cut the glass and fit it to the center of the frame, which may not coincide with the patient's eye for whatever reason. Maybe the patient's anatomical features or the frame is a little fancy, and these points are not taken before actually cutting the lens. So there are manual methods and lensometer. Lensometer will tell you the optical center very easily, but there are some very versatile manual method which can be very easily demonstrated to the patient also. I'll just show you, like, for example, I'm showing this video. Once you are seeing this, you take a vertical line and just keep your spectacle frame. Okay, I will show it again. Keep the spectacle frame and see through that vertical line. The vertical line above and below the frame should basically coincide with the line seen through the spectacle. That line you have to draw. Okay, so I'll just show you once again. Like you are just seeing that vertical line. So outside and inside should coincide, and that is the line that actually patient sees. At the same time, you can also turn it by 90 degrees and actually see that the outside line and the inside line are exactly in line with each other. Then you get a mark like this. So this center, the intersection of these two, is the optical center. If the patient wears this, his center of the eye or the cornea should be at the intersection of these two lines. Otherwise, the patient is actually having a prismatic, it's a deserted lens. This is one. There's another method. You can probably spot a overhead light and keep the spectacle frame and see that you get two images. Once you keep the spectacle frame horizontal and see that the overhead light cast a reflection. The anterior and the posterior surface of the glass will produce two Purkinje-Sampson images like cornea. I'll just show you that. Like here, you can actually see there are two lights here. Okay, one light from the first thing and the second. You have to coincide the two lights. Where they coincide, you have to close one eye to avoid a parallax, of course. So once that happens, so the two lights, I'll show you once again. The two lights have to coincide with closing one eye, and you can make a point there. So that should be the optical center. Okay. And the final thing is most important. You don't have to do anything. Let the patient be sitting there only. The patient need not remove the spectacle. You sit in front of the patient at the eye level, close one of your eyes, take a torch, and ask the patient to look straight and put this torch onto the spectacle. You will see two, one big, one small reflection, one from the anterior, one from the posterior, which is the like a Purkinje-Sampson image of the cornea. You have to move your uh, torch in such a way that they both coincide at one point. Where they coincide, that is the optical center, and that should actually coincide with the cornea. Let me just check in this patient. So there are two lines. We are checking the right eye. There's one broad line on small. They coincide now, and it is much away from the eye. Now we are checking this eye. There are two Purkinje-Sampson images. Now they coincide. It is away from the eye. Let me kind of show you again. So the two images on that basically from a torch it is. So they are coinciding now, and you can mark it there, or you can just know that it is not with the aligned with the visual axis, like in this case. So this is a very simple method by which directly you can know that these spectacles are not centered. So patient comes and sits. You take a torch, close one eye, and move it in such a way, and immediately within 10 seconds, you can know that this spectacle frame is not properly centered, and all the problems of the patient are because of decentration. So you are not at fault. You have given the right correction, but the optician, the optical person has not made the glasses correctly. It is their duty to make sure that they take the measurements before so that the visual axis has to go through the optical center. The way they have cut the lens and fitted it to the frame is erroneous. So you can shift the blame onto them rather than onto yourself. And finally, a few tips. Never change a well-adjusted glasses needlessly. I know optical shop business is very remarkably very profitable, but please don't do it, especially if you have a complex refraction. And never prescribe a large cylinder for a first timer, and never prescribe a high reading addition. And please reassess the need for bifocals in myopes. And in a young person, please use this near vision as a guide for a high myopic correction. Whenever patient has a high myopia, they are underusing their accommodation. So don't give the full correction. See whether they're also N6 with that correction. And common mistakes in vision checking, let the patient not close the eye with their hand. And patient with a spectacle, you can probably put a triangular piece of paper between the eye and the frame so that they don't have to close the eye. And in children, please, they may not memorize their lessons, but they'll memorize the alphabets in the chart. So be sure. And near vision recording. A reality check is your consultation room is brightly lit, and you have got a very bold letters on your near vision chart, and the patient reads happily N6. But in real life, that kind of contrast is not there, that kind of illumination is not there. The patient may find a problem. So most times, what you make them read in your clinic should simulate real life situation. Okay. So, and finally, when you're doing an autorefractometer, make sure the head is erect, because you can get cylinders, okay, if the patient is tilting the head. And it should, keratometry should be the first, or the autorefractometer. If you're doing autorefractometry after putting a dilating drops or after doing a paracane or a contact procedure, you may get wrong readings. And very tall or short persons can tilt the head, you may get a wrong axis for your autorefractometer or a keratometry. Okay, I think with this, I will close. These are some of the tips that I wanted to share in our routine refraction practice. I think we have spent a nice 1 hour on the commonly applied practical pulse that can make your refraction very enjoyable and also comforting to the patient. Thank you so much for your patient hearing.
Thank you, sir. Is Dr. Mahesh Babu, you're here?
Yes, madam,
Dr. Mahesh
I'm
Babu,
here.
yeah. Would you like to share
So he is
any
representing
thoughts on?
Dr. Namrata Sharma because he is from the scientific committee AOS.
Yeah. Yeah.
So, madam,
Any?
as all of us know, sir is a master in refraction, and we have heard about refraction. This is like a refraction master class from the master himself. So nothing is left to add to that. Sir has covered everything so perfectly, and he made it so interesting, especially for beginners. Refraction seems very confusing, but after hearing him, I think it will become very interesting rather than confusing. And sir has told about all the points, whatever required for refraction, practical points which most of the beginners would miss or ignore. So excellent coverage by the sir, and I think sir has covered everything there. I don't think anything we need to add to that.
See, I have done refraction, you have to do over refraction.
Actually, one thing I would really like to say, as easy as sir makes it sound and so interesting, advice to the PGs, unless they do it themselves, there is no way they can master it just by listening to video so many times. And a simple subjective correction or retinoscopy itself takes many hours of practice to master. So there is no getting away with theory. They have to practice, keep on practicing. The other point is regarding presbyopia. Sir has elaborated very nicely, and I would like to add that you have to spend some chair time when you do presbyopia counseling, especially old patients, first time users. Many times they come when they're post 45, and if they don't understand about the image jump, they tend to look at the footpath from the lower part of the glass, end up having a fall, and all because you have not told them how to use. See, we see so many patients in a day, but for them is the first time they're coming to the OPD, first time they may be entering a hospital sometimes. So it's very important. Then next is regarding choosing the frame. Sir has covered, but I did have experiences initially wherein people want fancy frames for presbyopia, for progressives. And then, once they buy those expensive frames, and we have to tell them that don't buy a very large frame. Otherwise, the near portion is at the lowermost end and they will be extremely unhappy. They have to change their frame. So this is something that we should keep in mind initially. Don't go for a very large frame in presbyopia correction, especially when you're giving progressive lenses. Then I think sir has given some nice tips when you want to delay, glasses for presbyopia. Many of us would not like to use glasses early. So I think some of those tips with, better lighting and adjusting the distance, that can always be advised. And many patients I have seen, they think that once they start using presbyopic glasses, automatically near vision improves even after you remove them. Very recently, I had a patient like that. So we must tell them that their vision, near vision will be good only when they use glasses, and when they take it off, they're not going to see. So many patients complain of this. It's very interesting to listen to their stories.
Actually, they have
So
another
that's
other issue with it. They say they came, they had a little problem. They started using glasses. They come and say, after your glasses, now I'm
Yes,
not
yes.
able to see anything with naked eyes. Earlier, I was able to see. That is
yeah.
again that they were overusing their accommodation. They were habituated. Now that they have the, ability to, relax their accommodation, see better. Now, when you take it off, that accommodation won't kick in again. So that's actually a good thing that is happening, but they probably ascribe it to the glasses that I'm not able to see now anything. I'm blind for near. So this is the usual complaint. But I feel presbyopia as a huge opportunity. It is a refractive problem which affects everyone. The patients are turning very intolerant to it. And when people before 40 will not understand what it is like kind of a menopause for all. Like you got to go through that thing till you get settled with the glasses, and glasses come with their own problems of logistics, financial burden, the dependence, and things like that. As I actually alluded, the future is probably lens-based procedures. Not all that cornea things that people are doing are all short-lived. They are invasive, and over and above that, you have to undergo a cataract surgery again on a later date. So maybe patients who are presbyopes with hyperopia, because people who are presbyope with a low myopia, they will not be very happy with anything, because always they can take off their glasses, distant glasses, and they can see. Their presbyopia is not a problem. Patients who are emmetrope or hyperopes, they are worst hit because they can neither see for distance or near. And for them, the presbyopia is very labile, because every time the age passes, their facultative hypermetropia becomes absolute hypermetropia, and they really have a very labile refraction. Nothing really suits them for a longer period. They are the ones who actually are very happy with a trifocal lens with a clear lens extraction, which is the future, or rather the present also in the select cases. I think that is where we need to have an open mind, and also looking at the lens not for the transparency but for the dysfunctional aspects of a aging lens is the future way. So I think that is what we can probably offer to it. And I would like to use in the same situation the next episode, the fourth episode, the last episode will be dealt by Dr. Sheetal Savur on 26th of this month, which is another very exciting opportunity, that is the refractive surgery. Refractive surgery is now going through a boom. India has a huge young population who are myopes. There is a huge opportunity, and we are doing very less. I think the youngsters have to now understand that they need to get aligned to this new development and the new need for refractive surgery. So Dr. Sheetal will be now covering the refraction aspects of a refractive surgery planning, and also the low vision aids, which is again a very highly underutilized thing. There are a lot of patients who are incurably blind, have subnormal vision, and the low vision aids is a very highly underutilized aspect of our care. So that is where these next topic becomes very interesting. I wish all of you will log into that particular last episode so that we can complete this AIOS webinar in a very fruitful way. Anyway, thanks to the scientific committee, Dr. Namrata, the head, and all the members and the AIOS for this wonderful opportunity. Thank you once again.
Thank you, sir. Thank you so much.
I think, Mahesh, you should conclude
Thank
as an
you, sir.
AIOS person. We are done.
Yes, sir.
Thank you, Dr.
I would like
Mahesh.
to add one more point before concluding. As you said that optical
Yeah,
center.
with this we can conclude.
Yes, madam.
Yeah.
Yes, madam, please.
Please continue. Please continue.
Yeah.
No, please
Because nowadays
continue.
the people are buying spectacles online, mostly from various online shops. So that the matching of the optical center and visual access is becoming a big problem, because there is no scope for matching that one. And even with a perfect refraction, when they get 6/6, but they'll not be happy with the glasses. So advice would be, if even if they go for online, So they should keep in mind that they must ensure the optical center and the visual axis of the spectacle of the patient should match, because almost every alternate, especially youngsters who are going for this fancy frames and all, that is a very common, difficulty we are facing when they come with unhappy patients when they come back to our OPD. They would have got the spectacles online, refraction is perfect, everything is perfect, but they're not happy with the glass. So mainly because of the fancy glass and the misalignment of this optical axis.
Also that the edges of the lens, they give lot of blurring. That is something that is not explained to many patients by the optometrist and also ophthalmologist. So they must be told that the clear vision is largely in the center and the periphery is bound not to be all that clear. Just this one line sometimes can make a lot of difference to the experience of the patient. Although we have better quality progressive lenses, still, I think this piece of advice goes a long way in improving their comfort and acceptance of the progressive lenses. So I think with this, we can perhaps call it a day. Yeah. Thank you very much, Krishna Prasad sir. Always a pleasure to listen to you any number of times on this topic. And thank you, Dr. Mahesh Babu, for your invaluable comments. And I think with this, we can end the program. Thank you and good night.
Thank you so much.